All right, first of all, good morning, everyone, and thanks for the organizers for the invitation. And today I'll be talking about mostly autoimmune hepatitis, PBC, and PSC. Let's see. All right. So these are the topics that we're going to cover today, mostly epidemiology, surveillance for some disorders, and then we'll cover heavily the clinical presentation and diagnosis and management. So when we look at the prevalence of this condition, you're looking about 17 cases per 100,000 persons per year. This is a disease that affects females. When you look at the causes of chronic liver disease, up to 23% of those disorders will be related to autoimmune hepatitis. In terms of liver transplant, in Europe, about 4%, and in the US, about 6% of cases. This is a disease that often presents in someone that is genetically predisposed. And then there's a triggering event, often an infection, hepatitis A, B, C. When you look at antibodies in those patients for autoimmune hepatitis, up to 50, 60% of those patients will have a positive ANA. Medications, and this is not the drug-induced liver injury that could resemble autoimmune hepatitis. These are patients that progress to the full spectrum of the disease. Toxins, and I feel everything falls between the idea of molecular mimicry. What that means for us, we thought these cells were very specific in terms of the receptors, but then we realized that some of those triggering factors, the amino acids, are very similar to the structure of those T cells. And when you have that patient that is genetically predisposed, they get that event, and then they trigger a very aggressive inflammatory response. We all kind of heard a little bit about some of the serologic markers for autoimmune hepatitis. We know ANA and smooth muscle antibody. Those are the ones that are heavily in type 1. Your LKM is something that you will see in about 3% of adults, but it's heavy in the pediatric population. Your SLA is very specific for autoimmune hepatitis. You will not see it often, but if you have a patient that is positive for SLA, that patient likely has autoimmune hepatitis. The antibodies, as you can imagine, they're not as reliable in certain situations, specifically because when you look at data in general population, ANA could be positive in up to 50% of patients without evidence of autoimmune hepatitis, but they're very helpful in the diagnosis. So let's start with type 1. This is the one that you're going to see in clinic very often. Could go from infants to elderly, 78% females affected. For boards, they like to add that questions, I don't know why, but the antigen, Asia-alloglycoprotein receptor. We talk about the antibodies. The HLA is mostly for research, but we know that patients that have a DR3 variant, they tend to have more aggressive disease compared to the ones that are DR4. 40% will have autoimmune, other autoimmune disorders. And then this is the patient that will present with an elevated IgG. Now, there's going to be a subset of patients, the ones that present in the hospital, where your antibodies could be negative in around sometimes 20% of patients, and the gamma globulin could be normal in up to 40% of patients. So in that setting, you might have to consider other ways to make the diagnosis, and that's where the liver biopsy could come into play. Now, type 2, if you see this patient in the clinic, often they present after a liver transplant, or they're already cirrhotic and decompensated. Very aggressive disease. The presentation could still very similar, but females up to 90%. We talk about the antibodies, and in this setting, the IgG elevation is mild often. So how patients present? And this will be someone that comes to your clinic, enzymes were 400, you check a month later, and now they're 150. So you have some variations in enzymes, but often it's going to be over 300 in most of those patients. For you, in terms of board question, this is one of those things that you need to consider in terms of disorders that will cause an elevation in AST, ALT over 1,000. Bilirubin often is not elevated unless the patient is presented with decompensation or severe disease, and the alkaline phosphatase typically is less than 2 times the upper limits or normal. When you see an adult, about 1/3 of patients will present already cirrhotic, In the pediatric population, you're looking at 50% of those patients. For histology and liver biopsy, for board's purpose, so your interface hepatitis, that's going to be the word that you're going to see often on the sample from the liver tissue. Plasma cells as well. The other findings are not as strongly associated, but it's something that you can see as well with the disease. The only thing that I will add at the last point is that steatosis, because of the rise in steatotic liver disorders, you're going to see a lot of patients presenting with both autoimmune hepatitis and fatty liver disease. Numbers anywhere between 13 all the way to 20% of patients. So it's something that we have to kind of remove from the guidelines in terms of the diagnosis, because we're seeing more and more of those patients now. So in terms of treatment, and this is probably the part that you should know more for these patients. And you have 3 different categories for treatment. These are the patients that definitely needs treatment. Very severe symptoms. Your AST over 10 times the upper limits are normal, or AST over 5 times the upper limits are normal with an IgG that is 2 times the upper limits are normal. Those patients, the biopsy comes with a lot of necrosis, a lot of tissue damage. That patient definitely needs treatment. These are the patients that, even though the guidelines suggest that it's a relative treatment indication, most of us often treat those patients, mostly because the data support that those patients will progress with time. And those patients fall in the AST of 3 to 9 times the upper limits are normal, or 5 times with an IgG that is less than 5. The histology, mild inflammation, interface hepatitis, and active cirrhosis. There's a very small group of patients that you should consider no treatment, because you can cause more damage than benefit. Specifically from that list, I would say the patient that is decompensated with inactive disease. That patient already is at the end stage of the disease, so likely you're going to cause more problems if you treat them. Very small group with AST less than 3 times the upper limits are normal, where you can monitor those patients. You do labs every 3 months or so, but if you see at any point that they're progressing, that patient you should consider for treatment. So how do we treat patients with autoimmune hepatitis? The main thing that you need to consider is this patient cirrhotic or not, and if this patient is presenting to the hospital with acute severe autoimmune hepatitis. For the patient without cirrhosis, you have a few options for treatment. We often use prednisone, 20 to 40 milligrams per day. You can use budesonide as well, 9 milligrams per day. Once you start the treatment and you see that the patient is slowly improving, after 2 weeks, you introduce the azathioprine. You start at 50 milligrams and then you titrate up based on response and tolerance. The reasoning behind waiting those 2 weeks is because occasionally azathioprine could cause liver injury, so you don't want to make the picture a little bit challenging for you. In terms of labs, in the beginning, those patients require frequent labs. I would say probably 2 weeks, because it is expensive. Patient will not come every week to the lab, but 2 weeks is something that is probably easy to attain. Once they respond, and that's mostly that the numbers are improving, and that often could be about 4 weeks or so, that's when you start tapering down the medication. And this is a big point for this disease, is you don't want to rush it. You take your time, you taper the medication slowly. You look in there almost 6 months sometimes to taper the medication completely. After you're able to achieve a point of biochemical remission, and what that means is complete normalization of your AST, ALT, and IgG. Those are the patients that you can come off completely of the steroids. You keep in on the azathioprine. Often they're going to be in a dose of 100 milligrams already. And then from that moment on, that's when the time frame starts to consider the 2 years that a patient needs to achieve before you consider withdrawal of the medication. For the cirrhosis, the biggest difference will be that you should not use budesonide in those patients. There's a risk of portal vein thrombosis, some complications. So that patient likely will be on prednisone. Azathioprine, if they're compensated, make sure that you check your TPMT activity. You can start that patient on azathioprine same way after 2 weeks. If they're decompensated, likely you need to wait until the patient stabilizes before you can consider adding something else. Some of those patients remain on low-dose prednisone instead of azathioprine. But after that, same pattern, if they respond, you eventually taper down slowly until they get to the point of complete biochemical remission. And for the one that present in the hospital, that one typically requires higher dose of steroids. Often you're going to use IV steroids for those patients, and then you switch them to oral. My experience is that when that patient presents and you start the IV steroids, the response is very quick. You should see that downtrend typically 24 to 48 hours after you start the medication. If that patient has cholestasis, you have to wait until that improves before you introduce the azathioprine. So that could take several weeks. But after that, same pattern. You monitor, you repeat labs often until they get to biochemical remission. But this is a patient that needs to stay on the medication indefinitely. You should not consider drug withdrawal in that population. The guidelines, for most part, support that most patients should at least go through a process of withdrawal as long as everything normalized. The time frame, 2 years, some of the guidelines suggest 3 years of complete biochemical remission before you consider that. If you're going to do it, a liver biopsy is very helpful. The reason behind that is that there is probably, I would say, between 16 to 20% of patients that if you do a liver biopsy in those patients, there's going to be activity that you're not seeing on your labs. If you see that on a liver biopsy, that patient is going to do poorly, just keep it on the medication. But if there's no active disease on biopsy, you start tapering down the dose slowly. If they're on azathioprine, 25 milligrams, you cut it down every 3 months. At the same time, you're checking labs at that time frame until you're completely off. Then after that, every 3 months for that first year, and if everything is stable, you can then proceed to 6 months surveillance. If they relapse, you have to do the induction again, and that patient needs to stay on the medication indefinitely. There's going to be a very small subset of patients that will fail treatment. That's going to be often less than 10% of patients. In that group, you have a couple of options that you could try. It's probably more common that patients will not tolerate azathioprine or steroids, which these two options as well will work for that population. So for mycophenolate, it's a good drug for patients that they're not able to tolerate azathioprine or steroids. It's not a good option for someone that failed the medications. Those patients will still do poorly. But if you select the patient correctly, you can see that 75% of those patients could achieve remission after 2 years. The dosing is going to be 1 gram twice per day. You titrate based on tolerance. GI side effects are the most common reason for patients to stop the medication, but often they can tolerate the medication well with the goal that you can suppress the inflammation. Now, Prograf is another option. We're using this medication more often now. It is a good drug for that patient that failed treatment. But as you can imagine, it requires more monitoring. You have to check levels, you have to dose it properly. The dosage can vary from one patient to another. That's the range that you typically will see, anywhere between 1 to 8 milligrams. The concentration that you look at often is going to be in the range of 5 to 7. Those patients require very high levels to suppress the disease. If you're able to achieve that, up to 75% will have complete biochemical response. You need to feel comfortable managing that medication because there's side effects that come with the use of Prograf that if you don't feel comfortable, you can cause more problems. A lot of times, those patients are already in a transplant center or being managed by the hepatology. But if you're in the community, in a place where there's no service, you might be the one managing that. Now, moving on to PBC. So primary biliary cholangitis, cholestatic liver disease. Same idea, we think it's related to someone that is genetically predisposed and there's a triggering event. You need 2 out of the 3 criteria to make the diagnosis. That is going to be an alkaline phosphatase that is elevated at least 1.5 times the upper limits or normal, presence of AMA that with a titer over 1 in 40, or other antibody that are PBC specific. If you don't meet the AMA criteria or the serologic markers, then the biopsy will help you in that setting, and you're looking at the florid duct lesion that's going to be probably on your boards as well. If they have any of those three, then you have your diagnosis. Keep that in mind that it needs to be in the right setting as well, and that goes with the disease that affects mostly females. I would say that the biggest difference will be in someone that presents with alkaline phosphatase, your AMA is negative. If it's a female, that patient, yeah, there's a high probability that could be PBC. If it's a male, you might start to consider other possibilities as the disease tends to be less prevalent in that population. We talk a little bit about that epidemiology, but females tend to be affected here. Middle age, the prevalence about 400 cases per million, and you see it in family clustering. In terms of treatment, ursodeoxycholic acid is the only accepted first-line treatment for the condition. It is dosed between 13 to 15 milligrams per kilogram. It is a drug that is known to slow down disease progression. When you look at transplant-free survival, significantly better if you put the patient on the medication. And most of the medications that you're going to see for PBC, they tend to work by allowing better excretion of bile. When there's stasis, there's inflammation associated with that, so all these agents will work directly in that setting. Around 2/3 of patients will have normal life expectancy if you start the treatment early. I would say probably what you could expect about 40% drop in alkaline phosphatase. So a lot of these patients, if they present with fairly high alkaline phosphatase, you can imagine that they probably will need a second treatment or second-line treatment to control their disease. And about 45% will not achieve complete control of the disease. So it's a fairly big number, but overall well-tolerated, minimal side effects, and very effective. So in 2016, you have obeticholic acid was approved at that point. Mechanism very similar in terms of the idea of allowing better excretion. The medication is started at 5 milligrams. You assess for tolerance. The most common side effect of this medication is going to be pruritus. And those patients already present with significant pruritus. Some of the times that will be the initial presentation, so you need to keep that in mind. If they tolerate, you can go to 10 milligrams. There's going to be a group of patients that you should not use this medication. That is a decompensated patient or someone with cirrhosis and clinically significant portal hypertension. You could cause more issues in those patients. Now, last year at AASLD, some of the data from the HERO study was presented. This is real-world data about the use of Ocaliva compared to their POISE trial, which was the clinical trial. And as you can see, the numbers are very good, especially if the patient can tolerate the medication. And when they compare that data to the POISE trial, very similar results. Significant reduction in relative risk of death, liver transplant, and hepatic decompensation. So if you're able to offer the medication to the patient and the insurance let you do it, then this is a good option for that population. Now, the fibrase is something that you will hear out there as another option. So bezafibrate is used heavily in Europe and Japan. It works with the PPAR receptor agonist, and you probably heard a lot of that during the previous presentation because it's being used in other liver disorders. But that specific receptor has very excellent results against cholestasis. It's the second-line treatment in Japan and often well tolerated as well, but there's some issues with abnormal liver enzymes and GI upset. In 2019, this study came out about bezafibrate as a second-line treatment for PBC. And this is just to show you that the medication is very effective in lowering the things that we want to see in those patients. Your alkaline phosphatase, AST, ALT, and then other things that we keep an eye on, platelet count and albumin tend to get better. Over here, this is a study that was published about 2 months ago, comparing your obeticholic acid and your fibric acid. When you see the drug discontinuation, very similar for both groups. For alkaline phosphatase, percentage of reduction, proportion of normalization, heavier in the fibric acid group. For ALT and bilirubin, that tends to favor your obeticholic acid. Overall biochemical response, better for the fibric group, and the odds ratio of improving pruritus also as well for the fibric acid. One of the issues that we have is that we don't have bezafibrate here in the US. Now, you can use fenofibrate, and my experience is that you can see very similar results at a dose of 145 milligrams per day. At the end, they're both good options. If you're able to get the medication on obeticholic acid with no side effects, I'll say probably that will be your choice here in the US. We're hoping to get more information about some of the other fibrates that we're studying, and maybe in the future, that will be your second-line treatment. So you have your diagnosis, you start the medication, you have to give it at least 9 to 12 months before you decide, I'm going to use a second-line treatment, because that's the time frame that it takes for ursodeoxycholic acid to achieve full response. If they fail, you consider one of your two options. Now, if they don't respond, one of the things that you will see with PBC compared to the other disorders is that there is a lot of research going on in this area, multiple medications, so that patient will benefit from a clinical trial. Pruritus, probably the most common complaint besides fatigue in that population, very challenging to treat. Here are some of the options that you have. They all come with their good things and bad things in terms of side effect profiles, tolerance, and response. From that list, I would say cholestyramine will be your first option, and you can consider adding some of the other ones in combination to that. Once you move on from cholestyramine, then it becomes a little bit more gray in terms of what you can use. Rifampin is the next one that are often used, but it could cause liver injury. It is dosed at 150 milligrams to 300 per day. It is an option, could be effective, but you need to monitor that patient closely. Some of the other medications, the results are kind of mixed in terms of response. And I have a few patients that the pruritus was so severe that they end up getting extracorporeal support, and could be also a reason to get liver transplant. This over here is to show you just a small sample of what's going on with PBC in terms of research. It's an area that there's a lot of data coming up. Recruitment typically tends to be a little bit better than some of the other disorders. As you can see, a lot of those medications targeting your PPAR pathway and also your FXR. There's another subset of studies evaluating pruritus and medications for management of that. There's already 2 medications approved in the pediatric population for genetic disorders that will cause pruritus, and those are being studied also in adults. So you're going to see a lot of data in the next few years, and likely eventually we'll have another second-line treatment that will be in the PPAR pathway. Now, moving on to primary sclerosing cholangitis. So in terms of definition, there's a few things that you need to consider in this population. So first of all, it's a chronic cholestatic liver disease. Often will lead to strictures in the intrahepatic and extrahepatic bile ducts, and is often associated with IBD. The IBD in that population is often pancolitis, heavily affected the right side of the colon. There's some backwash ileitis, and this will be one that will have rectal sparing. So that's the biggest difference compared to your typical UC. The risk of dysplasia is very high for those patients as well. For small duct PSC, similar presentation, but on imaging, you will not see changes in the intrahepatic or extrahepatic bile ducts. You need a liver biopsy to confirm the diagnosis, and often what you see is onion skin findings, and that's for boards. That's the buzzword that you're going to see. You can have patients with both PSC and autoimmune hepatitis. Those patients, you treat them like autoimmune hepatitis. Your secondary sclerosing cholangitis is something that you need to rule out. That is often related to infections, stones, and if that is the case, they can still progress to cirrhosis, but it's not an autoimmune disorder. Your IgG4, that's another presentation which is also autoimmune. They tend to report to steroids. And then you have your dominant stricture that is based on ERCP, diameter less than 1.5 millimeters in the common bile duct and less than 1 millimeter in the hepatic duct. Up to 60% of patients with PSC eventually in their lifetime will develop a dominant stricture. High-grade stricture, that's going to be based on your MRCP, and that's going to be 75% reduction in the common bile duct or hepatic ducts. And then irrelevant stricture is mostly having a stricture with symptoms, cholestasis or cholangitis. So the prevalence, about 14 cases per 100,000 persons per year. Compared to autoimmune hepatitis and PBC, this is a disease that tends to affect males. Females present later in life. Younger age, between 25 to 45 years of age. And then you get up to 80% that will have IBD. In terms of symptoms, the most common symptom will be fatigue and pruritus. Now the rest there are hit and miss. Some patients will present straight with portal hypertension. Some patients will present with cirrhosis to start. There's going to be some metabolic bone disease, some issues also with vitamin absorption, especially if there's cholestasis. Malignancy, so cholangiocarcinoma, the lifetime risk for PSC patients to develop cholangiocarcinoma is about 10 to 16%, so very high. So it's something that is also could be the initial presentation in some of those patients. Now you have your patient, you suspect PSC, you get your history, you get your labs, alkaline phosphatase is elevated, you get your MRI, MRCP, you have a stricture, you rule out secondary causes, then you have your diagnosis. If it's not clear, you have a couple options. You can either repeat the MRI, MRCP in 6 months to a year, do a liver biopsy, or send the patient to a center with experience in that population. If it's normal, you do the liver biopsy. If it meets the criteria based on findings, then you have your diagnosis. If not, proceed to look for other causes of elevated alkaline phosphatase and abnormal liver enzymes. So for the management, probably the best intervention that you can do for those patients is to refer them to a clinical trial. There is no first-line treatment for patients with PSC. There's been studies on immunosuppressive agents, antibiotics, and none of them have shown positive results. You could consider using ursodeoxycholic acid, probably more in the range of your PBC patient. That is mixed. There are some places that will tell you, no, I don't use it, or I sometimes take it off the medication. But there is a subset of patients that will improve and the numbers will normalize. So if you get to that patient, then you can continue with the medication because potentially there could be some benefits. If you see someone with your PSC autoimmune hepatitis, treat them based on the autoimmune hepatitis guidelines. Remember to do screening for varices in those that meet the criteria. If they have cholangitis, you treat them, you get your MRCP to rule out a relevant stricture. And then the surveillance. These are patients that will benefit from getting yearly MRIs, looking for cholangiocarcinoma or ultrasound for gallbladder malignancies. If you see an ultrasound, a gallbladder polyp, this is the type of patient that you need to take that gallbladder out because the risk of malignancy is fairly high. And this is for you just to kind of go over later on, but in someone that presents with a relevant stricture, ERCP is going to help you kind of figure out what is the risk of having cholangiocarcinoma. And there's different pathways based on the results of the FISH and cytology. Often you end up repeating that ERCP in 3 months or 6 months until you either rule it out or confirm the diagnosis. If you have a mass, be careful about taking samples or taking a biopsy because some of these patients will benefit from a liver transplant for management of cholangiocarcinoma. We mentioned there's not a lot of studies out there, but cilofexor is the medication that I'm probably going to start hearing in the next few years. This is data from the phase 2 trial. It was an extension, 96 weeks. And some of the markers that we follow, alkaline phosphatase, ALT, and AST, you can see that the medication is able to lower those numbers to the point that almost achieve normalization. Once you stop the medication, all those numbers start to go back. We have to wait a little bit more. Now the phase 3s are going, so hopefully we'll get more information. Very small subset of patients, 52 patients. So that's the number that you will get from most PSC studies. It's very hard to enroll patients with PSC. And just to conclude, this is mostly to show you some of the patterns in the disease from the clinical presentation, talking about your IBD, the cholangitis, the different pathways from bacterial translocation, things that could trigger the inflammation, the type of colitis. We talk about cure, but still we're very far away from even achieving a medication that could control the symptoms, but those are some of the options that you have. The cancer risk, we talk about the surveillance, colonoscopy as well, remember, every 1 to 2 years because there's a risk of dysplasia, and then the management of cirrhotic like any other cirrhotic. We need a lot of more research, very hard to recruit patients. This is a disease that we are far out of what we need to achieve to control the disease, and patients often present very sick by the time they see you. And it's over there. All right, thank you.